Hello and welcome to the topic Allergy and its responses in the module Immunology. By the end of this module, you should be able to outline the natural history of allergic diseases, list out the types of allergic responses, describe the mechanisms of allergic sensitizations, outline the manifestations of allergy, which are urticaria, angioedema, and anaphylaxis, and lastly, discuss occupational associated allergies. Let's get started. Let's first start with a brief history of allergic diseases and how did they get their names. It began when two French scientists observed that an extract of a sea flower could be safely injected into dogs on a first occasion, but induced a severe and fatal reaction when injected several weeks later. This adverse reaction took the form of cardiovascular and respiratory collapse and was given the term anaphylaxis. It is now known to be mediated by IgE, mast cells and their mediators, and is a typical type 1 reaction. The second observation was made using hyperimmune horse serum to treat the life-threatening infection diphtheria. They found that an initial injection was usually uneventful, but a fever, rash, joint pains, and renal damage often developed about 8 days after the subsequent injection of horse serum. This became known as serum sickness and is now known to be mediated by circulating immune complexes formed from anti-horse antibodies formed in response to the first injection complexed with complement and is a type 3 reaction. The term allergy was initially used to describe any form of altered reactivity that followed exposure to antigenic material, but currently is most often used to refer to the symptoms and signs that accompany adverse reactions to non-microbial antigens. Allergic diseases are characterized by a latency period between exposure and symptoms. This may involve immunoglobulin E or non-immunoglobulin E mediated responses. In the context of hypersensitivity to allergic reactions, there are 4 basic hypersensitivity reactions as originally classified by Gell and Coombs in 1963. The distinct responses were characterized based on the primary effector molecules and immune cells involved in each reaction. Allergic responses can be broadly classified into 2: IgE-mediated and non-IgE-mediated. An IgE-mediated allergic reaction is mediated by IgE antibody and mast cells and is sometimes called immediate type hypersensitivity. It involves the initiation of T helper 2 cytokines such as interleukin 4 and interleukin 13, leading to production of immunoglobulin E by the B cells, and once IgE is produced and secreted, it binds to the mast cells and basophils. Upon activation, these cells degranulate and release soluble allergic mediators such as histamine and leukotrienes, which act on smooth muscles, sensory nerves, mucous glands, arteries, and eosinophils. A non-IgE mediated or delayed type hypersensitivity response is a T cell mediated response and characterized by excessive inflammation. The most distinctive feature of this type of hypersensitivity response is the delay observed between allergen exposure and immune response. Following sensitization, subsequent exposures result in elicitation of the non-IgE mediated response characterized by the secretion of pro-inflammatory cytokines. Mechanism of allergic sensitization. So prevention of allergic diseases may be divided into two categories, which are the primary prophylaxis and secondary prophylaxis. Primary prophylaxis blocks IgE specific sensitization, whereas secondary prophylaxis avoids disease expression despite prior IgE sensitization and prevents the progression of the atopic march. Manifestations of allergy. These are urticaria, anaphylaxis, and angioedema, and are amongst the clinical manifestation of an allergic reaction depending on the severity of the reaction. Urticaria is a transient erythematous swelling of the skin associated with itching which usually resolves within 24 hours. Urticaria lesions itch. They have a central white wheal that is elevated and surrounded by an erythematous halo. The lesions are typically rounded and circumscribed. Characteristically, hives should blanch with pressure. They generally resolve within 24 hours. Angioedema, previously known as angioneurotic edema, is characterized by the swelling caused by edema in the deeper dermal layer. The overlying skin may appear normal. Swelling of the deeper layers of the skin, angioedema, commonly accompanies urticaria. This swelling often results from the same inflammatory processes that cause urticaria. Angioedema generally occurs on the extremities and digits as well as the areas of the head, neck, face, and in men genitalia. It is often described as being painful or burning. Anaphylaxis is a systemic allergic reaction mediated by massive histamine release, hemodynamic instability, airway or breathing compromise, and death. When any one of the following three occurs within minutes or hours of exposure to an allergen, there is a high likelihood of anaphylaxis. Involvement of the skin or mucosal tissue, plus either a respiratory difficulty or a low blood pressure causing symptoms. Two or more of the following symptoms are after a likely contact with an allergen. Involvement of the skin or mucosa such as hives, swollen tongue and itchiness, respiratory difficulties like dyspnea and stridor, low blood pressure, and gastrointestinal symptoms which includes crampy abdominal pain, diarrhea and vomiting. And lastly, low blood pressure after exposure to a known allergen. So what can cause allergies? The most common trigger is food. Examples of food that are frequently associated with anaphylaxis are peanuts, wheat, nuts, seafood, milk, eggs, sesame and chickpeas. Medications or drugs. Any medications may potentially trigger anaphylaxis. The most common ones are beta-lactam antibiotics, followed by aspirin and NSAIDs. Venom and insect bites. Venom from stinging or biting insects such as ants, bees, wasps may cause anaphylaxis in susceptible people. And lastly, latex allergy. Latex allergy is included as part of type 1 hypersensitivity and also type 4 hypersensitivity as well as irritant contact dermatitis. Lastly, occupational associated allergies. Occupational associated allergies are immune diseases and are the most common illnesses that affect workers. They include occupational asthma and contact dermatitis have been reported to show increased incidence in those at occupational risk. This table shows the various allergens and what are the occupations that are at risk. Healthcare workers, hairdressers, cosmetologists, individuals working in manufacturing and automotive industries, cleaning and janitorial staff, food processing and packaging workers, animal handlers, and individuals working with metals. we have come to the end of this topic. Thank you.